discussion is going to be a general discussion in regards to lasers, infections, and inflammation, whether this thing has got something which is of clinical application to us in surgery, but also just to have a look in regards to the management of the infection. So I'm going to introduce you to our two speakers today. And our two speakers today consist of myself. Many of you will know me because I've been involved with training with many of you through the BioLase group. But also I'm here with my colleague and great friend, Dr. Stephen Parker. And Stephen is an amazing laser dentist who, as he was saying earlier, was I think the first in the UK to get a laser. He's got a very impressive portfolio of achievements since, because he's a past president of the Academy of Laser Dentistry. He's also the course coordinator for the very highly regarded General University Advanced Masters Program in Laser Dentistry. And he was my mentor, and he's a prodigious author. He's the author, along with his friend and colleague, Don Colucci, of one of the best-selling laser textbooks ever, which was produced by Springer 2 years ago. And we're both currently studying for doctorates. He's studying at De Montfort University in Leicester, and I'm again in the UK at the University of Birmingham. So we're being very active in postgraduate circles, trying to get our materials out there to share some new concepts. We both have a shared passion and interest in photobiomodulation. So it's a very great pleasure for us to share with you some of our thoughts and insights. For some of you, this is going to be totally new material. For some of you, you know a lot about it. So for those who already know a lot about it, bear with us, because we will be introducing elements where we hope to spark off some thought. And for those of you new to it, well, there's always so much more that we could say than we have time for. However, this is going to be the beginning of what we hope is going to be a vehicle which you can all benefit from in respect of learning more about lasers in dentistry, as well as particularly in respect of healing, repair, and regeneration. So we'll provide some information at the end of this presentation as to our forward plans. So over to you, Stephen.
Thank you very much indeed, Mark, and good morning, or whatever your time difference is. Good day to everyone. This is the first meeting, as Mark says, that we've attempted to carry out as a forum online. We're more used to hosting meetings, and the photograph you see there is our first meeting that was carried out on the Isle of Wight, very close to Mark's practice last year. Delta as a group is made up of Mark and myself as co-directors, together with close colleagues, each of whom is an expert in their own chosen area of lasers in dentistry. When we consider that lasers in dentistry precisely span 30 years, I suppose it's fair to say the first 20 years was to do with finding out and developing surgical techniques and the precise physical interaction of laser photonic energy with tissue. And during the last 10 years, the attention has changed very slightly towards the hidden effects that we put down to uneventful healing, and the ability that we can influence the tissue response through the application of certain laser wavelengths. And the purpose of today is not to give you an exhaustive tutorial on photobiomodulation, but to perhaps dip in and dip out, first of all, in areas of phototherapy, photobiomodulation, one or two applications within the dental setting. And then finally, Mark will then round up the forum today with a few slides talking about the virus of the moment, i.e. COVID-19. So lasers, with regard to infection and inflammation, the two enemies associated with so much of our soft tissue manipulation, And when we think of soft tissue, of course, we also include the soft tissue element of the tooth and the live pulp. The principles of phototherapy we'll be looking at today, and as I say, one or two clinical applications. Over to you, Mark.
Well, it's been used as a therapeutic agent over the centuries by different civilizations. And so for thousands of years, I think the human race has been aware of the potential healing benefits of light. Although more recently, we've started to focus on the directed application of it, and the medical and dental benefits of this are causing a good deal of current excitement, because we've woken up to the fact that we've actually got quite a powerful tool in our hands that we can use to direct and to change cellular metabolism. The image you can see here is of the glorious sunshine in South Africa. We were in South Africa a few years ago, and this is at midday I think it was in January, which is the height of their summer. And at the solar zenith, there's a tremendous amount of energy coming from the sun. And that energy is largely in the visible spectrum, but there's a significant element which is in the near infrared, the very small element which is in the ultraviolet. And so in terms of power, it's amazing the amount of power that we get from the sun. I mean, look at those figures, 1500 watts per square meter. I mean, wow, you know, but that translates, when you do the mathematics, down to 150 milliwatts per square centimeter. And that kind of irradiance is something which maybe resonates with those of us with an interest in photobiomodulation therapy, because that's pretty much a sort of standard delivery rate for power for photomedicine. And the UV elements, the very short wavelengths, it's only a very small percentage of the amount of incoming radiation, which is just as well, because it's a very strong source. I mean, short wavelengths carry an awful lot more energy than the longer wavelengths. And an even smaller percentage of that is in UVB. And UVB, it's only about 5% of the ultraviolet. And so the amount of UVB present is remarkably small. Yet its biologic importance is tremendous. I mean, look at this. I mean, without UVB, you can't form vitamin D in your skin. Vitamin D, it's a bit a misnomer, because it's less of a vitamin, it's more an essential hormone. And it's formed from a type of cholesterol in your skin. And without that high energy UVB interacting with it, it can't be converted into the precursor of vitamin D3. Vitamin D3 then gets metabolized into a form which is calcitriol, which is an essential directed metabolite inside the cells, as we'll see, with some substantial significance, both in terms of bone metabolism. And here you can see a bit of a laundry list of effects associated with deficiency of vitamin D, such as osteoporosis, issues related to periodontal disease, failed implants, surgical issues to do with failed grafts and what have you, as well as with a worrying associated increased hazard associated with things like diabetes, cardiovascular disease, and even some cancers. And the reason I flag this up now is because one of the effects is related to our immune system, and so asthmatics, who are particularly vulnerable at the moment in the light of the current pandemic of the COVID-19 virus. They're at special risk, and if you have asthma and you're deficient or insufficient vitamin D, then you're very, very much higher risk of developing pneumonia, because vitamin D, in its circulatory form, it's in the form of 25 hydroxy vitamin D, and it's taken up preferentially by, amongst other cells, the epithelial cells lining the respiratory tract, including the bronchoepithelial cells. And it gets metabolized within the cell by 1-alpha hydroxylase into a substance called calcitriol. And calcitriol is a very important gene transcription factor, which stimulates the production of some antiviral material, cathelicidin, which is something which is specifically kills viruses and respiratory viruses. Plus, it's involved in the transcription genes associated with the reduction of a whole variety of pro-inflammatory cytokines, and it stimulates the generation of some antiviral interferons. So anybody who's short on vitamin D is at much increased risk of developing an upper respiratory tract infection. And I put some references there, one of which was a recent systematic review and meta-analysis, and it found a direct inverse relation between vitamin D insufficiency and deficiency and the risk of developing respiratory tract infections, including pneumonia. Now, although we don't have the evidence to show that this is specific to the current coronavirus, I, for one, aren't waiting to find out the results of that study. So I've been using a daily supplement of vitamin D as a spray in order to give myself a boost, in the hope that this will help reduce my susceptibility to the virus and for any sort of level of added protection, because vitamin D insufficiency is a huge problem. Particularly in the Northern Hemisphere, because from October through to March, there's not enough UV present in order to form the vitamin D that you need in your skin. So it's a risk factor that we can actually do something about. Another effect of light is on the pineal gland. And as anybody who's ever traveled long haul will know, when you change time zones, you suffer from jet lag. And that's associated with the suppression of the production of melatonin by the pineal gland, because there's a pathway from the retina to the suprachiasmatic nucleus, which sits just above the pineal gland. And when it's activated, it suppresses the manufacture of melatonin. Melatonin in the brain is the thing which entrains the circadian rhythm. And the circadian rhythm is where there's a sort of a switch between the two halves of the autonomic nervous system, between the parasympathetic, which is your nighttime cycle, where your immune system's active and you're getting mitosis, and this is where you are in your kind of your healing cycle, and the sympathetic nervous system, which is your sort of daytime cycle of being alert and aware. And people who've got sleep disorders are much more susceptible to infection, as well as possibly to various cancers, as well as to metabolic syndrome. And so the regulation of light is something which is essential to our healthy metabolism. Another effect of light, which anybody who has ever got sunburnt will know all about, is how intense light stimulates the melanocytes to produce pigment. But they don't just produce pigment, they're also very active in the generation of some very important neurochemicals, including serotonin, which is like the happy drug, you know, noradrenaline, dopamine, as long as a whole bunch of hormones. Melanocytes are a very interesting lineage of cell. They're, in terms of embryology, derived from the neural crest. And neural crest cells, aside from forming the entire peripheral nervous system, are also, for we dentists, of interest because the origin of odontoblasts as well. They can almost be seen as being like an extension of the peripheral nervous system. So it's not just about tanning. And melanocytes, in terms of these neurochemicals, these are things that regulate mood, which is why in a bright day you feel good, you know, and you feel happy. And whereas in winter, some people get depressed. So we shouldn't be too surprised at the effects of light and the effects of light, because these are all things which we're very used to in our daily lives. So when we start to think about manipulating light and using it for medicinal purposes, for those of you new to this, please don't think it's too strange. I mean, one final example, just before I pass over to Stephen, is in regards to the medical use of blue wavelengths of light in neonates, because some neonates, due to the immaturity of their organs, produce excessive amounts of bilirubin. That bilirubin can be toxic. It's a neurotoxin if it crosses the blood-brain barrier. And so they use blue light phototherapy, which isomerizes the bilirubin into a form which can't cross the blood-brain barrier. And it gets these infants through that vital window of the first month or two of life while their organs mature, and it protects them from brain damage. And they've been doing this medicinally for the last 60 years. So over to you, Stephen.
So we can move towards concepts of phototherapy. And one question we may care to ask is, does it have a potential role? We think of these therapies and therapeutic avenues as being relatively modern. This slide identifies what at the time was a very common disorder, which is skin tuberculosis, lupus vulgaris, and the work of Niels Finsen at the turn of the 20th century in pioneering the application of UV light in order to help treat these individuals suffering with this disfiguring and often fatal condition. And as you see, he was successful in receiving the Nobel Prize. He didn't invent phototherapy, he gave an emphasis to phototherapy. And as we get into these current days of COVID-19, we see that there are ways in which phototherapy can be utilized as part of a sterilization procedure. This is a photograph taken from the media, which shows an operating theatre where they are exposing it to UVC for a period of 10 to 15 minutes, sufficient to neutralize that environment and to kill off any viral and bacterial strains that are there. As far as dentistry is concerned, we have to ask the question, where does phototherapy fit into our everyday life, and especially our lives when using laser photonic energy? So photobiomodulation, to some may be a difficult word, some you'd have to just break it down, photo, bio, and then modulation. This is a relatively newly accepted word in the past 5 years, whereby up till then, a number of terms were applied: low-level laser therapy, cold lasers, and as often as not, the problem or the clue is sometimes in what it is delivering. Modulation suggests that it is neither stimulation nor inhibition. And the application of photonic energy to a target cell or target tissue area will have a myriad of effects dependent upon the chosen target and also the incident wavelength. It's necessary to just remind us all that there is a direct inverse relationship between photonic energy and wavelength. The longer the laser wavelength, the lower is the photonic energy. And so the choice of the wavelength is important. Now, we may see a number of interactions with tissue, and the slide that we're looking at the moment is a breakdown of some of the effects that can occur. This is taken from a paper by a Russian scientist, Tina Karu, in 1991, and she postulated that when we take a cell, and in this case it was a simple cell, a fibroblast, and subject it to a certain incident wavelength, that a number of effects were seen to occur. Notable amongst which was the production of adenosine triphosphate, the essential energy of the cell. As a result of that, and we'll look at this in slightly greater detail in just a moment, but as a result of that, there is also the release of one or two other agents that in themselves can exercise a secondary stimulatory role within the cell. Nitric oxide released from the production of ATP is a potent vasodilator and may well result in an increase in local circulating blood and lymphatics. And together with that, we may see that there are other compounds that are produced, superoxides, that have an effect on the transcription, i.e. the cell's ability to produce RNA and DNA, and consequently mitotic activity whereby the cell will duplicate. There are a myriad of changes that are postulated when we shine certain laser light. As dentists, of course, we're not used to looking at cells, we're used to looking at tissue. If we think of our target tissue as oral mucous membrane or gingival tissue, we may be able to influence the changes within the tissue relative to the wavelengths that we're using. There has been a tremendous amount of interest on a fairly narrow group of wavelengths running between the visible red and the near infrared, round about 900, 950 nanometers. This particular group of wavelengths has a particular effect on soft tissue in that it has a very high scatter coefficient, and the scatter itself is best viewed as being a gradual diminution over distance of the density of individual groups of photons. As the photonic density reduces, so the impact on target cells is reduced. And whereas we may be excising or vaporizing tissue at the center of laser tissue interaction with our tissue, at a distance from that wound, we may see that the scatter coefficient reduces the potency of the concentration to a point whereby we begin to modulate those cells. In summary, effectively, when carrying out minor oral surgery using our lasers with this particular group of wavelengths, we may see that we are rewarded for correct surgical technique by seeing a degree of uneventful healing. In effect, you're getting two lasers for the price of one, a surgical laser that will deliver ablation, and at the same time, some form of interaction with the surrounding tissue, whereby there is a reduction in inflammation, there is an uneventful level of healing and tissue repair, and added to which a reduction in the pain that the patient may feel. These are the classic triad of effects that we see as clinicians when we apply given wavelengths. Now, it has to be said at this stage that that is a very narrow group of wavelengths. And if you could just go back one slide there, please, Mark, if you wouldn't mind. Thank you. And if we are honest, we will acknowledge readily that there is a very wide group of commercially available lasers, from the so-called blue and green lasers at the short end through to the carbon dioxide lasers at the far end of the infrared spectrum, the near infrared spectrum. Now, when we are using those lasers, we may also see that there is a reward in that the healing appears to be uneventful. There may be a degree of analgesia, and we have to look at ways in which we can interpret these clinical signs and relate back to the science. This is my particular chosen subject with my thesis, my doctoral thesis, and Mark is at the same time looking at similar effects in terms of dose. And so we are acutely aware of the fact that we have a wide range of laser wavelengths, but the research that has been done has concentrated on that very narrow band between 600 and 950 nanometers. We can look at dental applications of PBM then in terms of looking at associated adjunctive use, looking at primary use in certain pathologies, and looking at an adjunctive use when we are dealing with non-surgical interaction, such as with accelerated tooth movement associated with orthodontics. Now, we will be aware that as dentists, we are clinicians within a very limited anatomical region. There's been a tremendous amount of investigation into all kinds of local distant sites, and systemic diseases, diabetes and such like, together with nerve repair. And this wonderful graphic taken off the web provides a fairly comprehensive list of the way in which these biomodulatory effects have been investigated using a wide range of incident laser wavelengths. So we should not be worried about photobiomodulation. It's there helping us in the background, whether we are inherently, primarily surgeons, or whether we are oral physicians dealing with the treatment of presenting pathologies. PBM is there to help us. What we need to do is to understand first and foremost the pathology itself. This is not a magic bullet, but to rationalize the laser wavelengths that we have, the target tissue that we are seeking to interact with, the anatomical relationship of that tissue to the surface, because of course, if we have a degree of scatter over distance, then we need to be able to apply the correct dose, but also to be readily aware that there is a degree of evidence-based science behind it. Over to you, Mark.
The common thread underlying many pathologies is that of inflammation. And so when I got interested in this, I asked myself, well, why do we have inflammation? I mean, what's the survival benefits of this thing? It's a curse. You know, it causes pain, it causes swelling, it causes inconvenience and loss of function, and it can be dangerous. I mean, look at pneumonia, you know, and that's where inflammation leads to patients not having the capacity to be able to exchange oxygen, and they're hypoxic. And of course, inflammation is triggered by trauma and as well as by infection. And it's an essential attribute to normal physiology. I mean, if you suppress inflammation, people don't heal. In orthodontics, teeth don't move. And so when you are subject to trauma or an infection, this is the primary trigger that starts off the cascade, which then leads on to the normal sequences of the defensive reactions of the immune system, as well as the beginnings of the processes which are associated with healing, repair, and we would hope regeneration. When inflammation goes wrong, in the sense of when you have persistent inflammation, you have chronic inflammation, things don't heal. You get progressive loss of structure and fibrosis, and chronic inflammation is one of the things that's associated with very many oral, as in periodontal disease, and systemic diseases, including Alzheimer's, diabetes, inflammatory bowel diseases, arthritis. I mean, it's a very long laundry list, and the common thread there is inflammation, particularly chronic inflammation. And also for me, particularly now I'm getting into mature years, it's of course a concern for me because it's associated with aging. And there's this term that's being coined called inflammaging, where consequence is senescent cells. The senescent cells, as opposed to dying, start producing inflammatory cytokines, and it starts to degrade systemic health. Now, just to take a look at the inflammatory phase, and then we'll have a look at how photobiomodulation as a therapy may be able to impact on this. In response to trauma, and this poor fellow clearly has been subject to trauma. I suspect it's dental trauma. This is an image I took off the net. He's got massive swelling, and that's because consequent to the surgical trauma, the immediate response was that the capillaries become very open for tissue fluids to escape, plus there's a massive neutrophil invasion to the area of the damaged tissues, and as a result there's this massive distension, and there's a whole complex cascade which you'll be relieved to hear we're not going to go into today, triggered off by chemokines, leukotrienes, which start to activate cellular processes associated with metabolizing damaged tissues, as well as a defensive reaction. And the neutrophils are the primary leukocyte troops that phagocytose and destroy bacteria or other pathogens. And they produce a lot of signaling chemicals, including all sorts of pro-inflammatory cytokines, which start to mediate the peripheral nervous system. So you can have pain, as well as swelling, as well as some febrile effects. And so inflammation, for its unpleasant effects, it's associated with the protective aspects of healing and repair. And but in the process, because the capillaries become very leaky, you end up with a drop in oxygen tension because the tissue is quite poorly perfused. And hypoxic tissues, ones which are operating in an anaerobic cycle metabolism, these are ones which, subject to stress, are more susceptible to cellular death, apoptosis. And that can then cascade, and it can result in further release of other inflammatory substances. So inflammation can lead to more inflammation, and on it goes. And so you end up with all the classic signs of pain, swelling, temperature, heat. And this is for all inflammatory conditions, whether it's trauma, as in dental trauma, or alternatively associated maybe with a viral infection, with an upper respiratory tract infection, which turns into a pneumonia. And so when we're thinking about possibly using phototherapy, does it have a role in killing bacteria or killing fungi or even killing viruses? And there are a number of therapeutic avenues that can be followed. One is directly, as Stephen was just discussing, where we can use photonic energy in order to start to activate cellular cascades, which can change gene transcription sequences, which can then modulate the cellular response. Or if we turn up the power, or if we're doing surgery, you can destroy bacteria. I mean, most bacteria are deactivated if you heat them above 50 degrees centigrade. Same for the fungi, and many viruses are very temperature sensitive because they're proteins, you know, and if you heat proteins above 60 degrees centigrade, you denature them. So you can sterilize an area just by heat. Or you may use it in conjunction with what's known as a photosensitizer, which is a chemical which can then be specifically activated by a chosen wavelength of light. And that chemical can then release highly active oxygen species, which can then kill bacteria and fungi. And although I looked to see whether they would have an antiviral effect, the only studies I could find related to methylene blue. So I suspect that that's more photothermal rather than a true photodynamic effect. Stephen mentioned earlier that one of the consequences of photobiomodulation as a therapy is that you get the manufacturing increase in levels of nitric oxide. Nitric oxide is a key vasodilator. And as you can see from this graphic on the left, it's a rabbit ear with a vein, an artery, and lymphatics before and after irradiation with the red end laser. And you can see there's a massive difference in the diameter of the lumen of all of those vessels. So the lymphatics dilate, they become less porous, and so you get good drainage, which is what you want if you're a patient who's got swelling. And as far as the arterial blood supply is concerned, the tissues are enriched with oxygenated red blood cells. And so this then will very much enhance the biologic capacity of those tissues to be able to form new matrix and to heal and to repair, as well as to withstand the stress and the insult of either something such as surgical trauma, or alternatively that of an infection. At higher levels of incoming photonic energy, you can achieve analgesia. So you can achieve a nerve block. The graphic is of a rat axon from a study by an Australian researcher, Roberta Chow, who found that at high enough energies of incoming energy, and this is below the level of energy necessary to permanently damage the tissues, she could produce these temporary axonal varices, which she postulated would impede the transmission of the wave of depolarization. But when it comes to analgesia and lasers, this is a particular area of interest for me, and we could have a whole separate lecture on this, you know, but suffice to say that you can use to very good effect photobiomodulation as a therapy for an analgesic effect. Last year, Steve and myself and our friend Praveen Irani published a paper in which we were looking at, in a very broad sense, at the origin of the analgesic mechanisms associated with photobiomodulation therapy. And as part of our analysis, we suggested that as opposed to thinking of photobiomodulation as being purely a binary event, where you're either getting a positive effect or no benefit, that in truth it was a multiphasic event, because at one dose of incoming energy, which seems to peak around about a level of radiant exposure of 5 joules per square centimeter, you could stimulate cells to produce more matrix and more bone and more collagen and to increase the rate of mitosis. Whereas on higher levels of incoming photonic energy, these were the optimum zones for generating laser-induced analgesia. And so there's sort of dose windows, and you can treat this more or less as a sort of a guide for administering dose. Over to you, Stephen.
Okay, next slide. Excellent. So we come to a point now of looking at some of the clinical aspects and how we may apply PBM. From a cellular point of view, just to recap, the graphic you see in front of you there is a representation of the mitochondrial membrane. It looks a little bit daunting. You'll notice there that the Krebs cycle is represented. We remember that from our days of biochemistry. But in essence, we are looking here at a turbine. Remember that the incident wavelength will have an associated level of energy. If that energy is sufficient to raise above a ground state a target molecule, then that molecule, as it then returns to a resting state, will release an electron, and this is representative of a cascade called the electron transport chain. Think of it, as you will, as a hydroelectric dam. The head of water in the dam is a source of energy by virtue of its mass. And as it passes through the dam, through the turbines will begin to rotate. And as they rotate, they will generate electricity. And that electricity in the form of energy can then be passed on to the home. In the same way, the cell is accepting some incident energy, not water, but in the form of photons. The molecular turbines that are within the mitochondrial membrane begin to turn. And as they turn, they then produce energy in the form of ATP. As a chemical consequence, there is the release of several byproducts, notably nitric oxide. We've already looked at that, together with reactive oxygen species, superoxides, that have a direct effect upon the nucleus, transcription ability of the cell. And this we can then see in terms of ability to control the immediate post-operative events, but also the early healing that may take place within our target tissue. Next slide, please, Mark. Here we see, if we can move on, thank you. Here we see an example whereby we are illuminating an area. In this case, it is a post-extraction dry socket. We would love to interact with the inflammatory reaction that's occurred, and also for the patient to be able to induce a level of analgesia and immediate pain control. Unlike laser tissue interaction that very often demands a contact mode, there are now a whole range of handpieces that allow us to deliver accurately a chosen level of fluence, energy density, to the target tissue. And I spoke earlier about the anatomical considerations. With many of the applications of PBM in dentistry on a daily basis, we choose to treat surface pathology, or we may choose to interact with deeper structures. And we must be prepared to administer the correct dose in terms of the energy density and the power density, together with how often we should apply it and over what period of time, how many days, how many weeks. This may be a single application in some cases. It may be a relatively short-lived repeat application, or, such as in the case of orthodontics, it may be something that we apply over a considerable length of time. And so we must be mindful of not so much saying, where are the tablets, can I take them, but more that we are in control of the laser energy that we are delivering to the tissue in order that we can optimize and maximize the potential for the tissue to react in a positive way. Next slide, please. In many ways, of course, the enemy lies within, because the patient, as the host receiving the applied irradiation, may suffer from a number of local and systemic disorders, and those in themselves, such as you see with the list here, those in themselves can interfere with our wish to deliver the correct dose. And we may have to take into account the fact that, first of all, there may be a need for adjunctive medication, but that also we should recognize the patient and the patient's condition and how that might influence us in our choice of correct dose. There are several groups of drugs that we may find have been administered to the patient, either by ourselves or by their medical practitioner, and those in themselves may cause us to think in terms of the adequacy and the optimization of PBM. One of the greatest areas of investigation, and certainly it is very much in the forefront of accepting photobiomodulation as a therapy within the States and FDA accreditation, is in the treatment of oral mucositis that is consequent upon immunotherapy for patients suffering from forms of cancer. The background to this is that most of the immunosuppressants and the cancer treating drugs interfere most potently with those cells that have a rapid turnover. Epithelial cells, such as those that line the entire alimentary canal, will suffer enormously. And as a result, the patients rapidly suffer from a level of inflammation and infection within the mouth that prevents and interferes with speech, function, eating, and so on. The ability to be able to render an adjunctive role with the use of PBM has been the subject of a great deal of investigation, not only to treat those patients who are suffering from this debilitating complication of their cancer therapy, but also, most importantly, as a precursor to their drug therapy. It is possible, by the application of suitable dose, that we can, in advance of their medication, we can condition the tissues so that the reaction itself will be in some ways modified. This slide represents, certainly Mark's current investigation as part of his doctoral thesis. I think, for the sake, Mark, of taking away your thunder, if you'd like to just say a few words to that, and then I'll finish off with the viral slide.
Well, I'm currently writing a systematic review looking at delivery parameters, because my interest in my doctorate is to do with the dose and how to deliver the dose. Because the thing is, we know we can do great things with PBM as a therapy, but then people say, well, how do you do it? You know, which may seem like a simple question, but it actually is a sight more complex than you might imagine. And so as a model, oral mucositis I found very interesting, because you have people who are essentially don't have a problem apart from the underlying systemic illness, you know, head and neck cancer or bone cancer, what have you. You do an intervention such as head and neck radiotherapy or cancer chemotherapy, and then they get this devastating oral ulceration, which is so severe that there are times when they have to discontinue treatment, and that affects both their morbidity as well as, sadly, their mortality. And prior to photobiomodulation as a therapy being accepted as a evidence-based approach, this was regarded as being something you could only treat with palliation. Whereas I've found in the paper that I'm currently presenting that the best outcome is when patients are preconditioned. So prior to the intervention with the radiotherapy or with the cancer chemotherapy, if they're exposed to some photobiomodulation as a therapy, it has a very dramatic effect in reducing both the incidence and the severity of this awful condition. And as such, this offers a lot of promise. And of course, the interest is, well, how can that be? And it would seem that by optimizing the biologic capacity of the cells to withstand the insult of the radiation or the chemotherapy, that the cells then are much more resistant to the apoptosis, the cellular death, and as a result, they're better able to withstand the insult. And I think that can apply perhaps more broadly in relation to surgery, as well as in other areas as well. So I find preconditioning a fascinating concept. Anyway, let's get back to something which is more mainstream in dentistry. I'll pass you over now to Stephen, who will talk to you a little bit about laser therapy and viruses.
The simplistic presentation of herpes labialis, patients find this, as a sufferer myself, and any of you listening who may also suffer from this, we know full well that it seems to come on at the worst time. There is the prodromal stage, then we get the development of vesicles. These ultimately will then burst and scab, and for the purposes of the few days that then follow, it can be quite disfiguring. This is one of the areas where over 30 years I've witnessed so many people telling me how to treat herpes labialis using lasers. And the one thing that I'm always reminded of is that anecdote abounds. The plural of anecdote is not data. And it is necessary to step back from some of these simple conditions, relatively simple conditions, and just take a rain check as to exactly what we're trying to do. For instance, some would advocate that it is possible to completely eradicate recurrent infection with this virus, notwithstanding the fact that the virus itself resides perhaps some distance away from the presenting area on the lip. And that, secondly, there are different staged approaches to treatment. Can we treat it as soon as it starts, the prodromal, or should we wait until the vesicles are present, or should we then move on until the scab is present? The latter being more an ablative therapy, whereby you're using a higher dose in order to resect the tissue with the associated risk of creating a scar. And this whole area, for such a simple presenting pathology, can be the subject of some confusion. Within the context of our presentation today, and I know we've given you an overview of photobiomodulation, we can think in terms of two presenting features here with the early presentation, the prodromal stage. We have a degree of inflammation and we also have a degree of pain. Both of these reactions are susceptible to photobiomodulation, and randomized clinical studies have shown to great satisfaction that if the patient can present themselves at this early stage, the suitable application of a given wavelength and dose can interfere with the progression of this lesion, so that very often the actual vesicle stage is either delayed or is sometimes avoided. And so our understanding of photobiomodulation is that we should be prepared to accept that it is there in the background, that despite the majority of investigations that have been carried out over the years, that it appears to be a feature in one way or another of all commercially available laser wavelengths, from the short blue lasers through to the longer CO2 lasers. It is maximally effective within that visible near infrared area. And as such, the majority of lasers being used nowadays, being diode lasers, that this is, as it were, a hidden benefit of being able to use the lasers within our daily practice. We should be prepared that we are treating, as often as not, infection or inflammation, and for the patient that if we can deliver some pain management for them, then they will certainly be welcoming the use of these lasers in their treatment. We will understand that through the 30 years that they've been available in dentistry, that the delivery of hemostasis, antibacterial action, together with the fact that we can now interact with soft tissues and hard tissues, it doesn't alter the fact that in the background, with many of these techniques, that we have photobiomodulation to thank. Okay, Mark.
I thought we'd conclude just with a few slides talking about the thing which has been very much preoccupying all of our minds, which is the severe acute respiratory syndrome coronavirus, which has been ID'd as number 19, COVID-19. Sadly, as we all know, this is a pandemic. The pathogenesis is it's spread by contact. It's highly infectious, and for us as dental practitioners, it's a huge risk because the aerosols we use spread it, and both our staff, other patients, and are at high risk. And we don't have an effective vaccine at present, and it'll be some time before one is available. And there would appear to be a very limited repertoire of drugs available to treat it. Among those drugs that they're exploring, in the University of Oxford, they've got a 3-wing clinical trial that's just started with, which has got through the ethics committee in record time. They're using chloroquine and hydroxychloroquine, which of course used to be their old school antimalarials, which have previously been retasked for dealing with some inflammatory disorders, because the Chinese doctors in Wuhan found that this reduced the severity and the incidence of the pneumonia associated with the COVID-19, although the studies, unfortunately, are just case studies, and they're, from the point of view evidence base, there are no checks and balances, but sufficient to say that it warrants further investigation. The other wing of it is to just use corticosteroids, which of course are anti-inflammatories, because the big issue for these poor hospitalized people who are intubated is they're drowning in their own interstitial fluid, and they just cannot get the oxygen to the system. They're in terrible pain, they can't breathe, and they're having to be intubated and ventilated. A further arm to the study is an antiviral drug called remdesivir, which previously has been very successfully used for treating Ebola, as well as for the Middle Eastern respiratory virus with MERS, which is very closely related to the coronavirus 19. And so there's some excitement there that that might offer a way forward. But the problem with all of these drugs is that they all have systemic side effects, and so corticosteroids, they're immunosuppressants, and by giving somebody who's got an infection something which suppresses their immune system, there can be superinfection present, and because often you're looking at people who've got systemic disorders of one form or another, they're quite poorly perfused, they're maybe already immunologically compromised, and by giving them corticosteroids, you're further reducing their ability to combat the infection. You want to give them some painkillers, so you give them some non-steroidal anti-inflammatories, and again, by suppressing the immune system, it's suggested this may aggravate the problem. Chloroquine itself, some people are allergic to it, or it can have some toxic effects, so none of these things are perfect. The virus itself, it's an RNA virus. It attaches itself, as with all respiratory tract infections, to epithelial or bronchoepithelial cells. and the effect of which is it triggers off an acute inflammatory response in consequence to disruption to cellular metabolism, and the cell dies, and it then sets off an acute inflammatory reaction, and through cytokines and chemokines you start to get all the classic signs of which we previously discussed earlier, to do with inflammation, swelling, pain, and a drop in oxygen tension. And so the tissues themselves are anoxic and operating in an anaerobic cycle of metabolism. Because of superinfection, you can then end up with patients developing sepsis because they can go to toxic shock, and it can kill them. So, you know, I mean, this is something which is the problem that we're all facing. But the comment that I have, and these are just personal views, that this is an acid-loving virus. When it's absorbed through endocytosis into the cell, it's the acid inside the lysosome, which is inside the epithelial cell, that strips off the outer coating to the RNA virus. And that's what activates the sequence that starts the virus from duplicating. And so it really benefits from an anaerobic environment. And so what I wondered was whether maybe by preconditioning with photobiomodulation therapy, as we've been seeing successfully used in the management of oral mucositis, I would speculate, and this is pure speculation, that this may potentially be of benefit in conditioning the cells so that they're less susceptible to viral invasion. Because, I mean, you know, we are clinically are at the highest risk, and particularly our medical colleagues who are dealing with very high dose exposure to the virus. So it is pH dependent, and so it needs an acid environment in order to duplicate, and that's how, in part, chloroquine and hydroxychloroquine work, because they're base, and basal things inhibit viruses, as well as having an anti-inflammatory effect. So we know that photobiomodulation as a therapy can kick a cell from an anaerobic cycle of metabolism into an aerobic cycle of metabolism, plus it can have an effect on the pro-inflammatory cascade. It can suppress it, and it can boost the immune system. So maybe, you know, who knows, photobiomodulation as a therapy may have a role. I can give you an anecdote where years ago, about 2 years ago, I was speaking at a conference in Copenhagen. And I woke up in the early hours of the morning before I was due to speak, and I had acute laryngitis. I couldn't speak. And so I was in a bit of a panic because I had 3 hours of lectures to deliver later that morning. And so among the steps that I took was I did some photobiomodulation therapy over my larynx. And do you know, I was able to speak for 3 hours afterwards. So, you know, this isn't science, this is an anecdote, but I just thought that in the light of the current problems, you know, maybe we should be looking not necessarily for patients, but to ourselves, you know, in regards to managing inflammation. I don't know. I mean, I'm just speculating. You know, I throw this out to you just as thought. Just to conclude, we've got all sorts of programs that we're going to be offering. And aside from the attendance courses, and sadly we had to postpone the one we were due to hold a week or two ago, and also the one in June. But when normal services resumed, we'll be back, and through our training academy, we'll be advertising some day-long courses where you can do some hands-on and learn all the necessary skills in order to put into action photobiomodulation as a therapy in your practice, as well as to update your knowledge in regards to the clinical aspects of laser applications. We'll be running some 2-day programs looking at hard as well as soft tissue lasers. It's the erbium lasers for surgery. Stephen runs a very fine laser safety program, and anybody that uses a laser really ought to have that one under their belt in order to protect themselves, as well as to better understand the legalities of using the laser. And also we're going to be running a lot more of these online programs, because given your support, perhaps this is an easy forum for you, rather than coming along to attend a course. And so it's sort of watch this space on that one, and we'll digest any feedback we get from you today. But if you feel this is of value, then please tell your friends, and so we'll keep you in the loop, and we'll be running some further programs. It's been a pleasure. I'm going to close this at this stage. I just want to thank you very much indeed for joining myself and Stephen today. And at this point, I'm going to call it today. So it's been terrific. Many thanks to our many friends who joined us. And so myself and Stephen, we're going to say goodbye. So goodbye for now. Bye-bye.